May I now invite the first speaker, Dr. Soumyava Basu. He will be talking to us on what to test and how much to believe. 8 minutes, sir.
I thought it was 12, but okay. Good. So I'll get started straight away. So what I'm
I can't
covering in
joke
this
like you.
talk is why do we test, how best we use our tests, and the concept of pre-test probability. I think those few people who are here, if you can take this concept with you, my job will be done. I'm not going to talk about the so-called uveitis workup. And if you want to know more about what I'm talking today, you will find it in these two papers. Especially the first one, which I think should be read by anybody practicing any kind of uveitis. So, why do we investigate uveitis? This question has to be asked because many infectious as well as a lot of non-infectious uveitis are actually diagnosed by the clinical pattern alone. And this includes almost all retinitis entities except the spirochetes and Bartonella, because these are all based on clinical pattern recognition and not any blood tests. Even for example, the viral anti-uveitis, fuchs uveitis, these are all clinical diagnoses. They don't need a test. Similarly, many of the non-infectious conditions are also based on pattern recognition. And I put B27 in brackets because although by definition it's based on a blood test, there are patients where you recognize by the clinical pattern and not by the blood test, which can be negative. So the reason why we want to test are to rule out or rule in an infection or a systemic disease, and sometimes to look for some of the baseline parameters like the immune status, fitness for therapy, and also for monitoring the treatment response. Now, when we do a test, how do you find out how good is your test? Now, I've put two questions here. One is, if the disease is present, will the test be positive? The other question is, if the test is positive, is the disease present? So which of these two questions do you think is relevant to us in the clinic? If you ask me, I would say it's the second one, because the patient doesn't come to you with the diagnosis of the disease. The patient comes to you with a positive or a negative test. So it's the second point which is going to be more relevant, and this is called the positive predictive value. So we all keep talking about how sensitive or specific a test is. That's actually not important. What is important is the positive predictive value, because the patient is not coming to you with the diagnosis, is coming to you with a positive or a negative test. For example, this case scenario, non-granulomatous anterior uveitis, acute unilateral recurrent inflammatory back pain. For some reason, the TPHA comes out to be positive. So what do you do? Go after the TPHA or go after the clinical pattern? Now, if you ask me, TPHA actually has a very high sensitivity and specificity. Okay, so do we believe that? No, because if the this means that if the prevalence of syphilis in acute recurrent alternating non-granulomatous anterior is just 1 in 10,000, remember the clinical background that we are looking at, then the positive predictive value is only 1%. So your TPH has very little role, even if it is positive, and even if it's a very good test in this case. So this is where the understanding of pre-test probability comes into the picture, and that is the prevalence of the disease before you order the test. And this will be based on the prevalence in the population, the ocular signs you are looking at, the patient profile, immune status, etc. Similarly, if the prevalence is low, the ocular signs are opposing. For example, if you have granulomatous KPs, you're not going to think about B27 even if your test is positive, right? And the patient profile. So how do you convert the pre-test probability to a post-test probability? For this you need what is called as a likelihood ratio, which is a combination of the sensitivity and the specificity of the test. And I've in fact put one of Dr. Kalpana's paper here where the sensitivity and specificity of quantiferon TB gold test in the diagnosis of ocular TB was mentioned. Based on these values, I calculated the positive likelihood ratio, and this we found to be 3.42 based on this particular study. So the way we convert the pre-test probability to post-test probability, we use something called as a Fagan's nomogram, which you may not use in the clinic, but it shows why this concept is so important. So if the central row is of the likelihood ratio, and if you put that red dot there for the 3.42, now if you see if the pretest probability is low, for example, non-granulomatous and anterior uveitis, history of inflammatory back pain, no TB contact, then if you connect it to the likelihood ratio, your post-test probability is just 10%. Now, if the pretest probability is slightly higher, intermediate uveitis, then your post-test probability goes to 60%. But serpiginous like choroiditis, a history of TB contact, and you have got a negative TPHA and test for sarcoid, now your post-test probability goes very high with the same likelihood ratio, with the same test. Based on your pre-test probability, your post-test probability has gone so very high. Okay, so I think if you have understood this slide, my job is really done. Two tests which are done very commonly in clinical practice, ANA and rheumatoid factor. How useful are they in your uveitis patients? I'm not talking about scleritis here. Now you see the prevalence of SLE in a uveitis patient is just that much, from 0.5 to 0.7%, similar values for rheumatoid arthritis. So even if your test is positive and there are no other systemic signs of SLE, your positive predictive value for a positive ANA in a patient with uveitis is just 4.4%. What do you do with that value? Nothing. It has absolutely zero relevance. Same thing with rheumatoid factor. Positive predictive value for just 0.7 to 2.45%. Zero relevance in a patient of uveitis, provided there are no other systemic signs of the disease. Okay. So please let us stop using these tests if there are no other systemic signs of these diseases. Okay. The last concept I want to convey here is the opposite of positive predictive value, which is uncertainty. And this I have bought, this is a new concept that I've learned myself, and it's given very well in this paper by Russ Van Gelder. Now, uncertainty is basically when you either have a very low or a very high pretest probability. For example, I'll talk about the very high pretest probability, serpiginous like choroiditis. Okay, typical lesions, very, very, very likely to be TB. Okay. Now, if your diagnostic tests for TB are negative in that patient, then you have a very high false omission rate. Similarly, non-granulomatous anterior uveitis with the inflammatory back pain, you get a positive TPHA test. Okay, then you have a high false discovery rate. So these are concepts which we actually face very commonly in our clinical practice, and we should be able to understand, use them as the time comes. Okay, not get carried away by the positive, negative, or values or positive values. So this was one patient who responded very well to corticosteroids alone. You see the choroiditis lesion there, and this fellow came back with this huge recurrence like this. Okay, he was treated with steroids because the MON2 test was negative. And this patient, when we have treated with ATT alone, you can see how the lesion has, kind of melted away completely with ATT alone. All right. So why do we screen? When we screen when the disease can present with any form of uveitis, it needs a lab test for diagnosis. The test should have high sensitivity and specificity, and the treatment should be markedly different from other uveitis entities. And there are just two conditions that fit into the need for screening. These are sarcoid and syphilis. Okay, the summary is the patient is always more important than the test. The positive and negative predictive values are more important than the sensitivity or specificity. And let us carry the understanding of pretest probability from here, and also of uncertainty, false discovery, and omission. And finally, very limited role of screening of or uveitis workup that we keep on doing in our practice. Thanks for your